You're listening to Who Said, a cardiology board review series. No fluff, just facts.
This episode is about preoperative cardiovascular risk stratification. We'll start with a step-by-step systematic approach for evaluating a patient's cardiovascular risk before surgery. We'll talk about interruption of dual antiplatelet therapy or DAPT for non-cardiac surgery, and then we'll talk about preoperative medication, holding, and bridging. The 2014 preoperative risk stratification guidelines were finally replaced at last in September 2024 by the 2024 AHA-ACC guideline for perioperative cardiovascular management for non-cardiac surgery. So this is very timely, and we're very fortunate to have these, and I will incorporate these specific relevant points from these in today's podcast. Let's start with a systematic approach. First, you want to determine the urgency of the surgery. If it is an emergency, then there is no opportunity for cardiac testing or treatment, and the patient just proceeds to emergent surgery with appropriate monitoring. Second, if surgery is elective or urgent, determine if the patient has either an active acute coronary syndrome such as unstable angina, NST-ACS, non-ST elevation acute coronary syndrome, or STEMI, ST elevation MI. Determine if the patient has active decompensated heart failure, significant arrhythmia, for example, new or symptomatic VT or high-grade AV block, or significant valve disease, for example, severe AS or symptomatic MS. If so, these conditions should be evaluated and treated first. Third and fourth, estimate the perioperative risk of MACE, major adverse cardiovascular events, using objective risk scores such as NISCIP, RCRI, or MICA, and we'll go over these. If the calculated risk is low, less than 1%, then no further cardiac testing is needed. Fifth, if the patient has an elevated perioperative risk of MACE, determine that patient's functional capacity, for example, using DASI. If the patient has moderate, good, or excellent functional capacity of at least 4 METs, no further cardiac testing is needed. Sixth, if the patient has poor, less than 4 METs, the clinician should consult with the perioperative team and patient about whether further testing will impact their decision-making. For example, the patient's willingness to undergo CABG or PCI, and the surgeon's willingness to perform original surgery or perioperative care. Now, let's touch upon some definitions in the terms we mentioned above. Risk of surgical procedures. What is low risk? Low-risk surgeries include generally breast, dental, thyroid, eye, minor orthopedics such as a meniscectomy, reconstructive, superficial, and minor gynecologic and minor urologic surgeries such as TURP. When they say 1% risk, what exactly is that risk? The percent risk refers to the average 30-day risk of cardiovascular death, myocardial infarction, and stroke without considering the patient's comorbidities. So that's the 30-day risk when we talk about low, medium, and high-risk surgeries. Stenting for symptomatic carotid artery stenosis is considered a high-risk surgery, whereas carotid endarterectomy for symptomatic carotid artery stenosis is considered an intermediate-risk surgery. Both stenting and CEA for asymptomatic carotid artery stenosis are considered an intermediate-risk surgery. Emergency surgery means life or limb is threatened if not in the operating room, where there is time for no or limited or minimal clinical evaluation, typically within less than 6 hours. Urgent surgery means there may be time for a limited clinical evaluation, usually when life or limb is threatened if not in the operating room, typically between 6 and 24 hours. Time-sensitive surgery means a delay of 1 to 6 weeks to allow for an evaluation, and significant changes in management will negatively affect the outcome. Elective means that the surgery could be delayed for up to 1 year. Now, how about testing such as pre-surgical stress tests, echoes, coronary CTA, left heart cath, and possibly PCI? Let's start with pre-surgical echo. Is that allowed? According to the 2024 AHA-ACC pre-operative risk guidelines, In patients undergoing non-cardiac surgery with new dyspnea, physical exam findings of heart failure, or suspected new/worsening ventricular dysfunction, it is recommended to perform preoperative evaluation of LV function to help guide perioperative management. That is a Class 1 recommendation. In patients with a known diagnosis of heart failure with worsening dyspnea or other change in clinical status undergoing non-cardiac surgery, preoperative assessment of LV function is reasonable to help guide perioperative management. 2A. In asymptomatic and clinically stable patients undergoing non-cardiac surgery, routine preoperative evaluation of LV function is not recommended due to lack of benefit. Class 3, no benefit. How about pre-surgical stress tests? Are those allowed? According to the 2024 AHA-ACC preoperative guidelines, for patients undergoing elevated risk non-cardiac surgery with poor or unknown functional capacity and elevated risk for perioperative cardiovascular events based on a validated risk tool, stress testing may be considered to evaluate for inducible myocardial ischemia. That's a Class 2B recommendation. In patients who are at low risk for perioperative cardiovascular events, have adequate functional capacity with stable symptoms, or who are undergoing low-risk procedures, routine stress testing before non-cardiac surgery is not recommended due to lack of benefit. Class 3, no benefit. Is pre-surgical coronary CTA allowed? According to the 2024 preoperative guidelines, for patients undergoing elevated risk surgery with poor or unknown functional capacity and elevated risk for perioperative cardiovascular events based on a validated risk tool, coronary computed tomography angiography, CCTA, for the detection of high-risk coronary anatomy may be considered. That's a Class 2B recommendation. In patients who are at low risk for perioperative cardiovascular events, have adequate functional capacity with stable symptoms, or who are undergoing low-risk procedures, routine coronary CTA before non-cardiac surgery is not recommended due to lack of benefit. Class 3, no benefit. What about pre-surgical left heart cath and PCI? According to the 2024 AHA-ACC guideline for perioperative cardiovascular management of non-cardiac surgery, in patients undergoing non-cardiac surgery, routine preoperative invasive coronary angiography is not recommended to improve perioperative outcomes. Class 3, no benefit. In patients with acute coronary syndromes being considered for elective non-cardiac surgery, coronary revascularization as appropriate and deferral of surgery is recommended to reduce perioperative cardiovascular events. That's a Class 1 indication. In patients with chronic coronary disease and hemodynamically significant left main coronary artery stenosis of at least 50% who are planning elective non-cardiac surgery, coronary revascularization and deferral of surgery is reasonable to reduce perioperative cardiovascular events. That's a Class 2A recommendation. In patients with non-left main CAD who are planned for non-cardiac surgery, routine preoperative coronary revascularization is not recommended to reduce perioperative cardiovascular events. That is a Class 3 no benefit statement. Now, let's talk about interruption of DAPT, dual antiplatelet therapy for non-cardiac surgery. During the first 30 days after PCI for any reason with a stent, do not discontinue that for any reason for any surgery. That's a Class 3 statement. If the drug-eluting stent was elective, for example, for chronic coronary disease, then after at least 30 days, 1 month, it is a Class 2A statement to be okay to hold the P2Y12 inhibitor, to interrupt it. After at least 6 months, then it's a Class 1 recommendation or permission to hold the P2Y12 inhibitor. If the drug-eluting stent was for STEMI, NSTEMI, or unstable angina, i.e. it was for an acute coronary syndrome, then after 3 months, it's a Class 2B recommendation to be permissive to hold the P2Y12 inhibitor, as opposed to 1 month if the drug-eluting stent was elective. And then after at least 6 months, is a Class 2A recommendation to be able to hold the P2Y12 inhibitor. You'll want to continue low-dose aspirin throughout all this time and resume the P2Y12 inhibitor as soon as possible after surgery. What does the 2024 AHA-ACC guideline for perioperative cardiovascular management for non-cardiac surgery say about timing of non-cardiac surgery after PCI? In patients with recent coronary artery balloon angioplasty without stent placement, elective non-cardiac surgery should be delayed for a minimum of 14 days to minimize perioperative MACE. That's a Class 1 recommendation. In patients with DES PCI placed for acute coronary syndrome who require elective non-coronary surgery with interruption of at least one antiplatelet agent, the surgery should ideally be delayed at least 12 months to minimize perioperative MACE. That's a Class 1 recommendation. In patients with drug-eluting stent PCI placed for the chronic coronary disease who require elective non-cardiac surgery with interruption of at least one antiplatelet agent, it is reasonable to delay surgery for at least 6 months after PCI to minimize perioperative MACE. In patients with drug-eluting stent who require time-sensitive non-cardiac surgery with interruption of at least one antiplatelet agent, non-cardiac surgery may be considered at least 3 months after PCI if the risk of delaying surgery outweighs the risk of MACE. In patients with recent, meaning 30 days, bare metal stent or drug-eluting stent, elective non-cardiac surgery requiring interruption of at least one antiplatelet agent is potentially harmful due to a high risk of stent thrombosis and ischemic complications, Class 3 harm. What about perioperative antiplatelet management post-PCI? In patients with prior PCI undergoing non-cardiac surgery, it is recommended to continue aspirin at a dose of 75 to 100 milligrams if possible to reduce the risk of cardiac events. That's a Class 1 recommendation. In patients with CAD who require time-sensitive non-cardiac surgery within 30 days of PCI or bare metal stent, or less than 3 months of PCI with drug-eluting stent, then DAPT should be continued unless the risk of bleeding outweighs the benefit of prevention of stent thrombosis. That's a Class 1 recommendation. So again, 30 days for bare metal stent and 3 months for drug-eluting stent for patients who require time-sensitive non-cardiac surgery. In patients with prior PCI in whom oral anticoagulant monotherapy must be discontinued before non-cardiac surgery, aspirin should be substituted when feasible in the perioperative period until an OAC can be safely reinitiated. In select patients after PCI who have a high thrombotic risk, perioperative bridging with intravenous antiplatelet therapy may be considered if it's within 6 months after drug-eluting stent or within 30 days after bare metal stent if non-cardiac surgery cannot be deferred. That's a Class 2B recommendation. What about perioperative antiplatelet management in patients without prior PCI? In patients with chronic coronary disease without prior PCI undergoing elective non-cardiac surgery, it may be reasonable to continue aspirin in selected patients when the risk of cardiac events outweighs the risk of bleeding, Class 2B. In patients with CAD but without prior PCI who are undergoing elective non-carotid non-cardiac surgery, routine initiation of aspirin is not beneficial. That's Class 3, no benefit. In this last section, we'll talk about preoperative medication holding anticoagulation, and bridging. AFib bridging anticoagulation is not needed if the pre-op CHA2DS2-VASc score is 4 or less, so that's a pretty high tolerance for not having anticoagulation. The last dose of low molecular weight heparin should be 24 hours pre-op, longer if it is a neuraxial procedure. Restart warfarin the night of the operation. When hemostasis is achieved, restart low molecular weight heparin. If low bleeding risk, then usually 24 hours post-op. If high bleeding risk, then 48 hours post-op. The timing of DOAC restarting is similar to low molecular weight restarting, and there's no role for reduced dose DOAC for reducing bleeding risk. Perioperative holding of warfarin in prosthetic valve patients. Situations where you can stop warfarin 3 to 4 days before surgery and have to start either low molecular weight heparin or unfractionated heparin in addition to the aspirin are mechanical mitral valve, mitral aortic valve that has risk factors such as AFib, EF less than 35%, previous VTE, hypercoagulable state, older generation mechanical AVR, for example, Starr-Edwards valve or any disc valve other than the Medtronic Hall has high thrombogenicity risk, or more than one mechanical valve. Note that some of these are the same risk factors used to bump the INR goal from 2.0 to 3.0 to 2.5 to 3.5 in patients with mechanical heart valves, aortic valves. The situations where you can stop warfarin 3 to 4 days before surgery and just be on monotherapy, aspirin monotherapy, pretty much all situations. Now let's move on to preoperative beta blockers. What do the 2024 guidelines say? In patients on stable doses of beta blockers undergoing non-cardiac surgery, beta blockers should be continued through the perioperative period as appropriate based on the clinical circumstances. That's a Class 1 recommendation. In patients scheduled for elective non-cardiac surgery who have a new indication for beta blockade, beta blockers may be initiated far enough before surgery, optimally more than 7 days, to permit assessments of tolerability and drug titration where needed, Class 2B. In patients undergoing non-cardiac surgery and with no immediate need to use beta blockers should not be initiated on the day of surgery due to the increased risk of perioperative mortality, Class 3 harm. How about preoperative RAAS inhibition? In select patients on chronic renin-angiotensin-aldosterone system inhibitors, or RAAS, for hypertension undergoing elevated risk non-cardiac surgery, omission 24 hours before surgery may be beneficial to limit intraoperative hypotension. That's a Class 2B recommendation. In patients on chronic RAAS inhibition for HFrEF, perioperative continuation is reasonable, Class 2A. Note that the AHA-ACC 2024 perioperative guidelines leave out any recommendations regarding pre-op ARNI holding. No current data exists regarding the perioperative role, harm, or benefit of the angiotensin receptor neprilysin inhibitor, or sacubitril valsartan. Given the important role of the RAAS inhibitor in preventing MI, stroke, heart failure, and declines in kidney function, large RCTs are needed to determine perioperative management of RAAS inhibition for patients planned for non-cardiac surgery. Now, how about preoperative SGLT2 inhibitors? In patients with heart failure undergoing elective non-cardiac surgery, sodium glucose cotransporter 2 inhibitors, SGLT2I, should have been withheld for 3 to 4 days before surgery when feasible to reduce the risk of perioperative metabolic acidosis. Canagliflozin, dapagliflozin, and empagliflozin should be stopped at 3 days, and ertugliflozin has to be stopped at least 4 days before the scheduled surgery. In patients with compensated heart failure undergoing non-cardiac surgery, it is reasonable to continue GDMT excluding SGLT2 inhibition in a perioperative period unless contraindicated to reduce the risk of worsening heart failure. In terms of perioperative statins, patients currently on statins and scheduled for non-cardiac surgery, you should continue the statin therapy as recommended to reduce the risk of MACE. That's a Class 1 recommendation. In statin-naive adult patients who meet the criteria for statin use based on ASCVD history or 10-year risk assessment and are scheduled for non-cardiac surgery, perioperative initiation of statin is recommended with intention of long-term use. Class 1 recommendation. And that's all I have for you for preoperative risk stratification, approach to devices, DAPT interruption for non-cardiac surgery, and preoperative medication holding.
This podcast is intended for qualified healthcare professionals and is designed for training purposes only. These materials should not be used for direct patient care or as a substitute for independent clinical judgment. For more educational content or to submit suggestions, visit www.raahu.com/meded.